My name's Dr. Brad Willsmore. I'm a cardiologist who specialises in heart rhythms. I'm going to talk to you about the most common heart rhythm disturbance, atrial fibrillation. One caveat, this is not meant to be a substitution for seeing a cardiologist in person. This is just a bit of my personal opinion on the management of atrial fibrillation. So first up, what is atrial fibrillation, which is also called AF or AFib for short? In the top panel here, you can see a heart in normal sinus rhythm. It has top chambers called the atrium, bottom chambers called the ventricle, and this is the electrical conducting system through the heart in a nice, beautiful rhythmical pattern, giving an ECG over here on the right that's regular and rhythmical. In atrial fibrillation, you can see the sparks in the atrium are firing, they're shimmering. The top chamber, the atrium, is fibrillating. And therefore, the bottom chamber, the ventricle, gets impulses irregularly, and so it's very irregularly irregular. And you can see here the rhythm is all over the place, and it's often a little faster, but not always. There are different types of atrial fibrillation, and as a general principle, it falls into thirds. About 1/3 have no symptoms whatsoever. About 1/3 have atrial fibrillation that comes and goes. Might get 5 minutes here and there, might get a couple of hours every few weeks. And about 1/3 of the population, when they get their AF, it stays there. There are two key components to the management of atrial fibrillation. On the one side, stroke, and on the other side, symptoms. And in fact, that broken chain there implies there is very little relationship between managing stroke and symptoms. If you have perfect symptom management, you can still have a stroke. If you have perfect stroke management, you can still have symptoms, and vice versa. The number one priority in managing atrial fibrillation is to prevent a stroke. We have a predictor of stroke in patients with atrial fibrillation. It's an acronym which is listed here. Heart failure, hypertension, age, diabetes, stroke, vascular disease, and age over 75 is also 2 points. What happens in atrial fibrillation is that you can form a clot which falls into the heart, can go up through the aorta, the main pipe leaving the heart, and a bit of Russian roulette can go to the brain, causing stroke, can go to the gut, causing ischemic gut, to the legs, causing ischemic legs, or any organ causing damage. Your risk of stroke on this acronym here, CHADS-VA, increases your risk of stroke. If you score 0, and the reason that's in green, some people might call this lone AF, and your risk of stroke per year is very low, to the point the risk of a blood thinner is probably greater than your risk of just living with your atrial fibrillation and accepting that very small risk of stroke. If your CHADS-VA score is 2 or more, it's red, indicating that your risk of stroke at 2.2% per year and above is greater than the risk of a problem or complication or issue on the blood thinners, and in general, blood thinners are recommended in those patients. With a score of 1, it's a lot more equivocal. In general, though, still most heart rhythm specialists would prescribe a blood thinner to this category, but a lot more discussion, debate in that category. A really important point that Australia, Europe, and the US have all clearly confirmed and published: aspirin is not effective at reducing the risk of stroke in atrial fibrillation. It's not to say it's not good for other things, but for atrial fibrillation, aspirin, which is an antiplatelet agent, is not the standard of care, and in fact probably causes harm in patients with atrial fibrillation. Another key point is that the amount of atrial fibrillation that you have has very little, if any, impact on your risk for stroke. And it doesn't quite make sense to most people, but there is some science behind it. And so here we have a figure of the risk of stroke from 100 down to 20% over 4 years. And interestingly, people who are in AF all day, every day, actually have a very similar risk of stroke to patients who have little bits of AF here and there, and nowhere near clinically significant. A p-value of 0.6 here. To be significant, needs to be less than 0.05. So the take-home message on this is the amount of AF is not a good predictor of stroke. What predicts stroke is the acronym CHADS-VA. That's a very strong predictor, not how much AF you're getting. And that is in part, some of the science behind it is shown here. These are some of the risk factors for developing atrial fibrillation. Obesity, lack of exercise, high blood pressure, diabetes are some of the reversible causes. There are more, including sleep apnea and others, smoking. And there are some irreversible or non-reversible modifiable factors like age and genes. They impact not only on the heart and the electrical wiring, but also the blood vessel walls themselves and the blood. And we had thought that that leads to the atrial fibrillation, which causes stroke. But in fact, we know that these changes can lead to stroke without the atrial fibrillation. Therefore, whether you have a little bit or a lot, you can still have strokes. Even if you're in this group and you have your atrial fibrillation suppressed or ablated, there's still a risk of stroke. Even if you have a cardioversion and you reverted back to normal rhythm, because of this, you can still have a stroke. And that's a really important take-home message. Moving on to symptom management, there are two distinct categories. We either go for rate control, that is, accept your AF but slow down the heart rate, and 110 is the speed limit, so to speak. If your resting heart rate is less than 110, then you're probably going to go okay. The alternative strategy for managing symptoms is rhythm control. And that's when we don't just accept that your heart's out of rhythm and slow it down, but we try to get you in the normal rhythm and keep you in the normal rhythm. And you can see beautiful, normal, regular rhythm here. There's a common saying amongst heart rhythm specialists that AF begets AF. There is some controversy behind it, but the punchline is the more time you spend in AF, the more likely you are going to be in AF, and the harder it is to get you back to the normal rhythm. And the analogy there with that image is like a nice, comfy, old leather chair. If you sit in that all day, every day, 24 hours a day for years, a groove becomes very well worn, and when you hop up, it doesn't spring back. The groove is stuck, just like your heart. If you're in AF all day, every day for years, you wear a deep groove, very hard to get back into the normal rhythm. Alternatively, if you have a brand new lounge, you sit in it for 5 minutes a year, you can imagine sitting in that chair, it still remains nice, soft and spongy, and when you pop up, the lounge pops out and springs up. It's in near mint condition, and the point here is that if you have a little bit of AF, you're more likely to get into the normal rhythm and stay there than hearts that have been stuck in atrial fibrillation for a long time and have worn quite a deep groove of AF. When it comes to rate control, we're accepting the AF and living with the atrial fibrillation. In this group, you need a lifelong blood thinner. We always prioritize lifestyle change regardless, and I'll speak to that in a moment. Typically no rate controlling medications, or one. Procedures are very uncommon. Interactions with healthcare professionals are less common than rhythm control, but you might have a few more heart issues moving forward. Rhythm control, on the other hand, similarly needs lifelong blood thinners. There's no difference in the risk of stroke. You need a blood thinner regardless of whether you go for rate or rhythm control. We still prioritize lifestyle changes. Often you're on a few more medications. Cardioversions and ablations are much more common. You're more in contact with allied health professionals, often because of those more interventions, more medications. But there is some evidence suggesting early rhythm control results in less stroke, heart failure, and death. And that was a really great study published just recently called Early Rhythm Control Therapy in Patients with Atrial Fibrillation. This was investigator-led, so not sponsored by companies. Lots of patients, randomized study, really great design, international, blinded outcomes, and it showed that patients do, as we've all expected for a long time, slightly better if you can get them in the normal rhythm and keep them there. So when you stack up the two side by side, as you can see here, the top two both need blood thinners and should adopt lifestyle changes: exercise, weight loss, reducing alcohol, smoking, etc. In the rate control category, you end up with a few less tablets, procedures, and interactions with healthcare professionals. But in the rhythm control strategy, you end up with less strokes, heart failure, and death, therefore improving, most likely in most patients, quality and quantity of life. Moving now to the symptom control management, there are three general categories: lifestyle, medications, procedures. And I'll go through each one of those with you now. In terms of lifestyle, it is actually fundamentally important. There is very few things where weight loss has such a profound impact as with atrial fibrillation. You have almost a 6-fold reduction in the burden of atrial fibrillation with 10% weight loss. It really is profoundly effective. As is exercise, not quite to the same degree as weight loss, but a 3-fold reduction in AF with a small increase in fitness. If you combine the two, it's what we call multiplicative, and you do exponentially better. So it really is important, even if you don't lose weight, that you're exercising, or if you're losing weight, that you're also exercising. But there are a host of other things, and to be honest, it's common sense things that heart doctors have been sprouting for years. Eat well, live well, don't drink too much alcohol, the less the better, don't smoke, keep your blood pressure in a good range, treat sleep apnea if you have it, common sense things. Moving on to medications. In Australia, medications typically consist of rate control drugs like the ones shown. The first line here are beta blockers, the next line calcium channel blockers, and the third line digoxin, which has had a recent trial and come back into favour somewhat. Rhythm control strategies tend to be a little stronger type medications, including sotalol, flecainide, and amiodarone. When it comes to procedures, ablation is the standard intervention for atrial fibrillation, but there are also cardioversions. Cardioversions are a temporary solution. Come in, you go to sleep, you get the heart reset, you wake up, you go home 95 times out of 100, 95% success rate in sinus rhythm. However, it's not a long-term solution. It doesn't keep you in the normal rhythm. An ablation, on the other hand, not only gets you to the normal rhythm, but hopefully increases the likelihood of keeping you there. And if nothing else, certainly most patients most of the time get a reduction in the burden of atrial fibrillation. How do we do it? You're in an X-ray table, sterile procedure, through the vein in your leg, lots of monitors, up into the heart. We go across to the left atrium, which you can see down here, and we burn a ring around the 4 pulmonary veins to try and isolate those electrical sparks. And this is a video showing that. Here we have the heart. Here we're into the left atrium. These are the pulmonary veins, and there are muscular sleeves that fire off sparks and irritate that atrium, triggering the atrial fibrillation. In an ablation, we go on the inside of the heart, and we burn rings around those 4 veins to try and isolate those sparks, stop them getting in, stop them tripping the heart over into atrial fibrillation. It's not a cure. And how good is it? Well, it varies. Everyone quotes different values and numbers and success rates, but as a general principle, if you want a take-home message, 2 out of 3 patients get a significant reduction in the burden of AF with about a 5% risk. But the less AF you've had, that old leather lounge theory, the better you tend to do. So if you've had very little atrial fibrillation, some people might quote up to an 8 or even 9 out of 10 success rate. If it's been 3 months or less, starting to approach 2 out of 3, more than 3 months or even more than 12 months, we're looking at maybe 1 in 3 chance of success, but all of them with an ablation would tend to have less atrial fibrillation than not having a procedure. So what is an AF ablation and how does it work? What are the logistics? Well, every lab's different, but here at our lab, most AF ablation, also called PVI, which is pulmonary vein isolation, which you know now, we're isolating electrically the veins, takes around 1 to 1.5 hours. Most patients stay overnight. We don't recommend driving for 24 hours because of the anaesthetic. Light activities the next day, full activities 1 or 2 days later. Blood thinners for everybody before and after, regardless of your risk of stroke. And the risks are around 5%. And it varies, but nasty things are uncommon. Less nasty, more annoying things that typically have a full recovery are more common and make up most of that 5%. The most common of which is bleeding, bruising, discomfort around the puncture site in your leg. In some people, they do need a redo AF ablation. As you can see here, sometimes you don't get perfect isolation of all 4 veins, which can be challenging. And if there's not complete isolation, the sparks can sometimes still get out. So some people do need a second or even a third procedure. It's always optional and elective and up to the patient, but in general, it's a slightly longer procedure, but everything else is essentially similar from a patient perspective. And all we're really doing in this instance is going back in, trying to find the gaps and fix them up. And then we look for extra things and do a bit of extra burning, and that's why it can take a little longer. So some take-home messages to leave you with. Most patients with AF can live a long, happy, healthy life. And I think it's really important you do understand that. So what we want to do is calculate your risk of stroke. And if you need it, consider a blood thinner, not aspirin. It doesn't work. We always recommend working on weight loss if you're overweight, doing exercise, keeping your alcohol to a minimum, not smoking, as well as those other factors like diet, sleep apnea, blood pressure, cholesterol management. Medications can help reduce the symptoms and maintain normal sinus rhythm. And early rhythm management of atrial fibrillation might improve some outcomes. So often we do like to catch up with you, not a year or 2 down the track, but sooner, to try and get on top of things early and improve the outcomes moving forward. That's all from me for now. If you want some more information, please visit the website drbradleywillsmore.com.au. We also have some contact details there.